The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Before I get started, I just want to say a big congratulations to past podcast guest Michael David Smith, who was recently inducted into the Colbert County Association of Volunteer Fire Departments Hall of Fame. The Hall of Fame was created a couple of years ago to honor people who have made significant contributions to emergency services over in Colbert County, and Michael David certainly fits that description. So congratulations to him, well deserved. The other inductees of the class of 2024 are Irene Oliver from White Oak, David Hubcap Hubbard from New Bethel, C.R. Thompson from Barton, Grady Malone from New Bethel, Lucian Tidwell from White Oak, Ronnie Wallace from Barton, Diane Renard from Locust Shores, William Sambo Hoagland from Barton, Ricky Rowling from Brickhattan, Junior Reiner from Highway 247, Matt Moore from White Oak, and Kelly Aday from Nitrate City. I know a few of those folks from back in the day, and all the ones on that list that I know personally are outstanding, so I'm going to assume the rest of them are too. So congratulations to everyone. I'm going to talk about Alpha-1-Antitrypsin Deficiency today. This is one of those things that maybe you read about, learn about, maybe you never actually see it. I got to meet a patient once that had it when I was a medical student. He came and spoke to our class about it, so I've always kind of remembered that. And everything you read about Alpha-1-Antitrypsin Deficiency says that it's probably underdiagnosed. Like the first sentence of any reference you read about it says, this underdiagnosed condition, ... So it's something that we probably should be looking for more than we do. The estimates I've seen as far as prevalence, somewhere in the neighborhood of 1 in 3,000 to 1 in 4,000 people have one of the genotypes, so one of the mutations that causes this. So, in my practice, statistically, at least one person ought to have it. There's always this conversation about common things being common. When you hear hoofbeats, you should look for horses, not zebras. But, there's a reason they say zebras and not unicorns. Zebras are real. We've all seen a zebra. I loved a line that someone said, I believe on the Curbsiders at one point, talking about rare diseases. And they said, a rare disease is rare, but when you look at all of the rare diseases combined, they're really pretty common. So I try to always keep stuff like this in the back of my mind and refresh myself on this sort of thing, because I definitely don't start out looking for the zebras. But sometimes you pretty quickly get to the point with a patient where you have to start thinking about the zebras when you just can't explain what's going on. Times when you're hearing people talk about this, they will just call it alpha-1 antitrypsin or abbreviate it AAT. But the problem is a deficiency of alpha-1 antitrypsin. I guess it's already enough syllables without adding the deficiency. So alpha-1 antitrypsin is an enzyme that is responsible for neutralizing neutrophil elastase. It also inhibits some other proteases, including trypsin, chymotrypsin, and thrombin. The enzyme is part of a bigger group of serine protease inhibitors, which are lovingly referred to as serpins, that play a role in a whole bunch of different diseases. And those diseases are lovingly referred to as serpinopathies. So why does this matter? Well, neutrophil elastase, as you can tell from the name, is also an enzyme. Its job is to destroy elastin, and there's a lot of that in your lungs. So if you don't have the enzyme to break that down, it destroys your lung tissue, which ultimately results in COPD. The other organ it very commonly affects is the liver, but it's not quite the same mechanism in the liver. What happens there is this mutated form of AAT doesn't get secreted from the liver cells like it's supposed to. It's made in the liver. It's supposed to be secreted from the liver cells and go do its thing. And so when it just sits there and accumulates, it starts causing the hepatocytes to fail. There are several different genotypes of this, and only certain genotypes will affect the liver at all. If you care, the genotypes associated with pathologic polymerization of alpha-1 antitrypsin within the endoplasmic reticulum of hepatocytes are the ones that cause liver disease. Don't you hate it when your endoplasmic reticulum gets all gummed up with alpha-1 antitrypsin? There can also be some skin manifestations, which I think are the most rare manifestations of this. So the main thing we worry about with this is lung disease. And a lot of times it presents in people who are smokers, so people who already have risk factors for lung disease, which makes sense if you're smoking and you're probably going to get COPD anyway if you have something that is already predisposing you to get COPD. then you might see that develop earlier or be particularly severe. The up-to-date article says that cigarette smoking can accelerate the onset of dyspnea by as much as 19 years, in case you needed one more reason not to smoke. Of course, occupational exposures to things that you breathe in that are not good for your lungs would also be a risk factor here. There's maybe a link to exposure to mineral dust, maybe a link with agricultural work, maybe a link with domiciliary kerosene, which I suppose means using a kerosene heater in your house. There was a study of New York firefighters who were exposed to debris on 9/11, and they saw a more significant decline in lung function or lung capacity, specifically FEV1, in all those folks who had any deficiency at all of alpha-1 antitrypsin. You'd think asthma would be a risk factor, but they haven't really been able to tease that out as a contributing factor to accelerated decline in lung function. So typically the way this is going to present clinically is just like COPD. The patient complains of dyspnea, cough, excess phlegm production, wheezing, two things that might clue you into the fact that you're dealing with an alpha-1 antitrypsin situation is that the COPD comes on at a much younger age than you would expect, and maybe also a basilar predominant pattern of emphysema. A lot of times with COPD, we think of it starting more in the apex of the lung, but there can be a lot of variability in that among individuals, so that one's definitely not a slam dunk. You might see bronchiectasis associated with this, or a spontaneous pneumothorax might be the presenting situation. Obviously, if this is affecting the liver, the patient might present with more liver symptoms or issues, so chronic hepatitis, cirrhosis, or even hepatocellular carcinoma. And with that one, that would be a situation where this just sort of pops up without someone having any history of liver disease previously. Because normally you would kind of see that coming, right? If it affects the skin, it can present as paniculitis, usually either on the upper legs or gluteal regions. You can see vasculitis, inflammatory bowel disease, aneurysms, fibromuscular dysplasia, or glomerulonephritis. So lots of potential extra pulmonary manifestations there. And any of those separately or together definitely would not trigger the alpha-1 antitrypsin bell in my head. So that would be a very complicated situation to figure out. So some things that ought to clue us into testing patients for this deficiency would be emphysema or COPD that shows up in a young person, like less than 45 years old, COPD that shows up in somebody who does not smoke at all or only smokes a little bit. The reference I'm looking at doesn't define what a little bit is, but I guess the person that smokes a cigar once a month or something like that, but I don't know what the actual cutoff would be there. COPD with predominantly basilar changes on a chest x-ray, family history of COPD or liver disease, adult onset asthma that is not responsive to bronchodilators. I guess I would put asthma in air quotes there if we're calling it asthma, but it doesn't respond to bronchodilators, and it's actually alpha-1 antitrypsin deficiency. So maybe that should say misdiagnosis of adult onset asthma. Adult asthma that seems like that might not be the right diagnosis. There you go. Any paniculitis or any unexplained chronic liver disease. Some other guidelines suggest testing every patient with COPD for alpha-1. If there's any history, either personal history or family history, of any kind of C-ANCA vasculitis, I had to look that one up. That stands for cytoplasmic antineutrophil cytoplasmic antibodies. How do you get to use cytoplasmic twice in the same acronym? That seems like cheating. I guess maybe the best known of those types of vasculitis is granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. I said that like I know that you don't pronounce the W, but I'm not 100% sure. Maybe it's Wegener's granulomatosis. You get the gist. And anyone who has a sibling with an alpha-1 antitrypsin mutation. I always find it very helpful when we're discussing some issue or collection of symptoms and the patient pops out with, well, my mother and my sister and my aunt and my grandmother all have whatever condition. That definitely gives you a direction to focus your efforts in. Always appreciated. So the way you diagnose this is just checking the serum level of alpha-1 antitrypsin. That should be a fasting blood draw, at least 8 hours of fasting. They should stop any kind of hormonal contraceptives or steroids 24 hours before the blood's drawn, and they should stop smoking before the test. The resource I'm looking at doesn't say how long before the test. That reminds me of the people who will say, hey, I quit smoking. You go, oh, congratulations. When did you quit? Right before I walked in this building. Had my last one this morning. Okay, good luck. I guess I would err on the side of saying at least 8 hours since that's the fasting time. I don't want to be sticking a smoker with a needle that hasn't had a cigarette in 24 hours. I don't know about you. I don't think there are any other special considerations about the lab. It goes in a regular red top tube. The normal range for the result in an adult is 110 to 200 milligrams per deciliter. That level goes up during pregnancy, and it's much higher normal value in newborns, 145 to 270 milligrams per deciliter. If you have a severe deficiency, which is defined based on the resource you look at as less than 80 or less than 50, and those folks are at much higher risk of developing complications. Oh, here's another resource that says 70. So if you're less than 80, that'd be a yellow flag. If you're less than 70, that'd be a red flag. And if you're less than 50, I don't know what's next. Black flag? No, we don't want to black flag these people. Flashing red, maybe less than 50. Anyway, lower alpha-1 antitrypsin equals worse for the patient. You can then do genotyping to figure out which specific mutations the patient has, which would tell you a lot more about things to look for down the road and how severe this is going to be. Genetic testing is not something that I would order. In this case, I would leave it to hematology, or if we're going to send them to a genetic counselor, that's definitely out of my wheelhouse. Obviously, to check their pulmonary function, we can order pulmonary function testing. If they get down to an FEV1 less than 80% of predicted after the bronchodilator, or if they have visible emphysema on chest imaging, then those folks are going to be candidates for augmentation therapy, which means you get infusions of the normal alpha-1 antitrypsin that you lack. It seems like that's a once-a-week infusion, and I guess that's once a week indefinitely. That's kind of a bummer. I don't know if that's a slow infusion or if it can be done relatively quickly, but that'd be a pretty big burden to a patient. Not as much as dialysis, but close. If we're looking at the liver, if we're talking about hepatic disease, of course, we're going to be looking at the liver function tests and also the alpha-fetoprotein. You're going to want some liver imaging as well. They recommend doing a liver ultrasound annually for folks that have known disease. As far as other treatments, there's not really a whole lot else to do that's specific for alpha-1. They can get a lung transplant if they have to, but I would assume since that does not fix the underlying problem that you would still have the same issue occur in the new lungs after a while. So I would imagine they're not in any hurry to do that. In studies of survival of lung transplant patients, it seems like the transplant helped their quality of life, but it didn't really help them live longer. And that's not nothing, obviously. For liver disease, really, you just monitor and treat as you would for any other kind of liver disease that might progress to liver failure. And same thing, they can get a transplant if they need to. But again, I would think you'd have the same problem with the issue occurring again over time. The big thing really would just be to stay away from other things that hurt your lungs and liver. So obviously we want these folks to stop smoking. We want them to stay away from alcohol. Although evidently there's really no evidence that drinking alcohol does affect the progression of the disease. So not as strong of a recommendation for that. And the other medications and things that you would use are just the same stuff you would do for COPD or liver disease. So nothing else really specific to alpha-1. Things that may be coming in the future, it may be possible to deliver the augmentation therapy or the replacement therapy via inhalation instead of infusion. It seems like it would be more convenient for the patient if it works as well. There's some effort being put into gene therapy, so actually fixing the underlying genetic mutation. Lung volume reduction surgery, just like you would do with somebody with COPD, might be helpful for this, but it seems like that's still real questionable. It seems like people who are just managed medically actually have better outcomes than the folks who get surgery with alpha-1 antitrypsin. So it seems like the surgery is probably more effective in people who just have regular old COPD without the deficiency. They have these endobronchial valves that they can use for treating COPD, which is kind of like doing lung volume reduction without actually taking out part of the lung. It's basically just a one-way valve that goes in there, and it does not allow air to go into the diseased part of the lung, but it does allow air to come out. So in essence, it's the same outcome. You're just shutting off part of the lung to improve the problem of hyperinflation or decreased surface area of alveoli available for gas exchange that you see with COPD. Pretty cool. There's 2 of those approved in the United States. I don't think I have any patients that have gotten those, but it sounds like a neat alternative to having part of your lung cut out. And it looks like they can be inserted with a bronchoscope, so definitely way less invasive than having a thoracotomy to have some of your lung taken out. And yeah, I think that's about all there is to say about alpha-1 antitrypsin deficiency. So for somebody like me in primary care, who's not a liver or lung specialist, really the most pertinent point here is just to be aware of this, right? If somebody shows up with weird lung disease and or liver disease that you can't explain or that they seem awfully young for, this should be on the differential. It's a pretty easy thing to test for. I have tested for it a few times. I've definitely seen GI specialists and lung specialists doing this testing as well. So there you go. Let's all get better at diagnosing alpha-1 antitrypsin. I decided I'm going to go through the alphabet and just pick a disease that starts with whatever letter to do for subsequent episodes. So for A, this is what popped into my head, alpha-1 antitrypsin. What's B going to be? I don't know. If you have any suggestions, feel free to reach out. If you know anything about alpha-1 antitrypsin, deficiency that I failed to mention. If you have any other feedback, I'd love to hear it or read it. Special thanks to our Patreon supporters. Thanks to everyone for listening. Have a great week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients, in that order.